So at least a vague understanding of the structure of the NHS would be a useful part of the preparation for an interview. We're just going to go over, say, how the NHS is set up, how it works, what the different institutions that work within it are. We'll teach all the basic information that you need to know about the NHS. So we'll start with what the NHS is. So the NHS was founded in the late 40s, and it was set up as a post-Second World War, free at the point of access institution to provide healthcare to the nation. And ever since then, the whole idea has been sort of from cradle, right at the birth, to grave, right at the end, to provide all the citizens with free healthcare right at the start. Not every country in the world has managed this and managed to do openly free healthcare. It's very difficult for a well-developed country to pay for free, completely free to everyone in the country healthcare, where no one has to pay anything at all and it's free at every step of the way. There are lots of other countries such as America or France or Germany. They do have good healthcare systems, however they tend to need to pay in a bit more into their healthcare than we do have to in the UK. So the current setup of the NHS is very centered around trusts. So the current setup of the NHS, you can think of it in three different layers. So we have primary care, which is your general practitioner. So everyone should have a registered GP who is in the UK that is getting some sort of healthcare, and your GP will be there for everything and anything when it comes to healthcare. And by that we mean they're your first port of call when something that isn't an emergency comes up in terms of your health. So if you're worried about your healthcare and you're not very, very actively unwell to the point where you need to go straight to A&E because you need to be urgently seen, then you go to your general practitioner, and they will do everything from administering vaccines, making sure that all of the right referrals are made for whatever your disease is to the appropriate specialty. They'll refer you to hospital services to have treatment or further investigations for various things. GPs will also go as far as ordering blood tests and x-rays and other types of radiology, and they'll make a very good effort at trying to understand what is going on with your health, and if they feel that they need some input from some more specialist care, then they can do a referral onwards to get some more input on whatever is affecting the patient. So moving on from primary care, we have then secondary care, and that refers to hospital services. So every hospital is considered secondary care, and they will often provide patients who are actually in hospital and need to stay in hospital with whatever care they need. And obviously this contains a lot of wide-ranging specialties. We've got the medical specialties such as neurology, cardiology, hematology, immunology, gastroenterology, the surgical specialties such as orthopedics or general surgery, neurosurgery, cardiothoracic surgery, vascular surgery. We've also got psychiatry, obstetrics and gynecology, and interventional radiology. And there's a long, long list of various services that we provide to patients in secondary care. In secondary care, obviously these patients are inpatients. The advantages of being in secondary care is that you can get investigations and treatment administered in a much quicker way than you can in primary care. So when patients come into hospital, they're physically there. So if you want blood tests, or if you need a medication prescribed, or if you need scans, or if you need any sort of information or investigations for the patient to try and figure out what's going on with them, or to try and treat them for their illness, they are there and there, and generally they are based in the hospital so that you can get them done quite quickly. And patients will stay in hospital for as long as they need to, and once they are discharged from secondary care, they then go back to primary care, and the hospital will send a letter to everyone's GP when they are discharged to summarise why they came into hospital and what treatment they had and anything that the GP might need to do and any sort of follow-up that the patient's going to get after they have been discharged from hospital. So after secondary care, we've then got tertiary care. And these are hospitals as well as secondary care, but they provide specialist services. So services where you have a particular illness that requires you to be treated in a hospital. However, the illness itself can be quite complex. It can be combined with multiple other illnesses. Potentially the diagnosis is unclear. So tertiary care will be specialist secondary care. Generally, these tend to be located in big city centres such as London, Manchester, Liverpool, Brighton, Bristol, Leeds, Sheffield. So we have lots of different places in the UK where we provide tertiary care, and generally these will be teaching hospitals associated with universities, and they'll have a lot more research coming out of them. There will be a lot more teaching of medical students there. So generally speaking, we have tertiary care in places where there is a higher amount of academic research and there's a higher level of specialisation in the care that they provide. I currently work in the Royal London Hospital in Whitechapel in the acute medicine unit, and quite often you're seeing patients referred in to the Royal London from various other hospitals in the sort of East London area. Potentially a patient has been admitted and they've had initial treatment within another hospital, and one consultant that's looking after the patient in a secondary care hospital will have a chat with a consultant in a tertiary care hospital and say, okay, this is what we've done so far, and we think there could be some scope for some more input if we could refer them on to you guys, and the patients will get moved and transfer over hospital. Generally speaking, for secondary and tertiary care, there are two routes for patients to be referred into secondary and tertiary care. The first is via your GP. So when you go and see your GP, they can refer you for an inpatient service or an outpatient service. So both secondary and tertiary care centres, so hospitals, will provide inpatient care for patients who are in hospital. They also provide outpatient care. So they have clinics where they view patients and they see them from their specialist's point of view. So they order tests and investigations and can prescribe medications, all from their clinics, to try and figure out what illness is affecting these patients and to try and treat them. The other route into secondary and tertiary care that isn't part of general practice is in via A&E. So patients show up to accident and emergency and they will either be admitted or they will be discharged, and an appropriate plan is usually put in place for them once they go home. I have worked in both general practice, accident emergency, medical specialties and surgical specialties, so I've had a relatively good broad mix of experience in the different types of the NHS. And roughly speaking, as far as the actual physical structure of the NHS goes, that's about as much as you need to know from what sort of services are provided by the NHS. So now we'll talk a little bit about the institutions that make up the NHS. Within the NHS, it's a constellation of various different what we call NHS trusts. So an NHS trust is an entity that is within the NHS, and it is generally responsible for providing the services that the NHS has to offer. So how we mentioned primary, secondary and tertiary care, NHS trusts are large areas that can cover multiple hospitals and multiple GP practices. So within the NHS itself, we have these things called clinical commissioning groups, or CCGs. They can also be called NHS trusts, so there's a bit of an overlap between the terminology there. Essentially, these CCGs are all throughout the country, and there are more than 200 different CCGs in the country. And essentially, the parent institution, the NHS, pays money to these CCGs, and they're the ones that are responsible for providing the primary, secondary and tertiary services in their specific area. There could be multiple hospitals within there and multiple general practitioners within there, and it is the CCG that is responsible for paying the GPs for their services and funding the hospitals to do their work. The rationale behind the CCG setup is it's an attempt to try and create some competition within a state-owned company. So this is delving into the realm of political philosophy a little bit. It's very difficult to get competition or value delivered when a state-run service is running an organisation. Generally, if there isn't competition, then there isn't an incentive to perform better at what you do. So this is the NHS's attempt to try and create competition within itself. So all of these 200 CCGs have specific criteria that they need to meet, such as a number of vaccinations that each patient or each child gets a year, whether they're all up to date with them. There are metrics for all sorts of diseases like screening for diabetes, making sure that various other metrics are all kept up to date. There's a criteria to make sure that all possible cancer diagnoses will be seen within a 2-week window. It's called the 2-week wait criteria, and all of these CCGs get measured on their ability to meet these metrics. One last one that's very important is the 4-hour window within being seen in A&E. Controversially, obviously, A&Es are frequently busy and these targets don't get met, but the idea is the government sets some targets for these CCGs to meet, the NHS pays the CCGs run the service and try to meet those targets, and they compare the performance between various different CCGs to see who is running their organisation as best they can. Roughly speaking, that's how the NHS is sort of set up and runs currently. Okay, so moving on to other institutions institutions within the NHS. There is the NICE, which stands for National Institute of Clinical Excellence. This was set up in the mid-2000s, and it's an organisation currently that ensures that the NHS is providing good quality services. So it provides guidelines on what specific treatment to have in specific circumstances, and that can be very useful as doctors to make sure that when we are dealing with a certain disease, there's a communally agreed upon best way to investigate and a best way to manage. Generally speaking, as a practicing doctor, that has been my exposure with NICE. I think that they also will investigate the efficacy of certain medications. Sometimes certain medications will have a certain cost, so there are various medications out there that are very expensive, and NICE will examine how expensive these medications are and how much value they are returning in terms of improvements in life and in qualities, as we mentioned in the medical ethics area, and they will decide which medications they are going to approve for NHS funding and which they don't. Roughly speaking, that's been my experience with the National Institute of Clinical Excellence so far in my career as a doctor. Next is the BMA, which stands for the British Medical Association. So this is the union that represents doctors and will negotiate with the government for the contracts that all doctors are currently working under. It will include negotiating things around pay and the frequency that they can do night shifts, how many hours a week they can do, and various other factors around their work. The BMA is the union that represents doctors in their negotiations with the government, the Department of Health, to decide what sort of contract they get and how good it is. Next is the GMC, which stands for the General Medical Council. This is the organisation that regulates doctors. So any practicing doctor working in the United Kingdom needs to be on the General Medical Council. It's been around more than 150 years. It was set up in the early 1800s as a way of regulating actually qualified medical practitioners. Apparently around the same time, there are a lot of quacks or not properly medically trained individuals who were giving medical advice. And the idea was, we have a publicly available register of all practicing doctors, then it allows all of us to be aware of who is a qualified medical professional. They also will regulate the register, so if there are concerns about a doctor's safety or conduct in how they operate as a clinician, then they will investigate that and consider removing a doctor or suspending a doctor if needed. The GMC offer guidance as well on how to approach working as a doctor in terms of ethics, and it's very, very good, as we mentioned previously, to be familiar with the GMC's guidelines on good medical practice.